This is my clinical practicum project for the University of Southern California MPH program. I'm Cynthia Sanchez. The clinic is part of Orange County Healthcare Agency and is known as the Testing, Treatment, and Care Clinic, or TTC. This is the organizational chart. My immediate supervisor was Jeffrey Wu, who's the Director of Clinical Services, and Dr. Christopher Reed, who's the Medical Director, and I worked very closely with Johanny Martinez, who is the epidemiologist. This data was collected in 2023 and reflects the reason for people coming to the clinic, which can be any number of things from having an STD, coming in for treatment, coming in for screening, asymptomatic screening. They could also be coming for pre-exposure prophylaxis or PrEP, and post-exposure prophylaxis or PEP, or as a sexual assault response team patient. The PrEP status by provider, part of the data collected, as you can see, provider number 3 has the bulk of patients that were not screened or has missing data. So between provider 1, 2, and 3, that's most of the cases that have missing data, and that we are trying to ascertain whether patients that are at increased risk for HIV are being offered PrEP services, and if they declined PrEP services, we document the reason that they declined for future use in trying to design more programs to increase the number of people on PrEP. So as you can see, about 25% of patients are on PrEP that use our services. Some of them from either from their own provider or maybe from an online service, so they're not a TTC patient for PrEP. 19.8 of them are our own PrEP patients. And then this is what's of concern to the 35% that are not on PrEP and 9.2 that were not screened. And then there was also 30.6% that had blanks or missing data. The public health competencies that were used, the foundational competencies were for interpreting the data and doing data analysis and designing a population-based policy program or intervention. So analyzing the data that was taken, and then talking with the PrEP patients and those at risk for HIV, and the PrEP providers, and designing an algorithm and tables for the providers to use for the assessing the risk and managing the PrEP patients were some of the things that were done in this project. The health services and policy competencies were assessing the role of the government in the distribution of health commodities and proposing a policy solution for a public health or health services problem. So again, that was working with the patients that were uninsured and underinsured. I developed a new policy for starting patients with insurance on PrEP before referring back to their own medical provider for those patients that have insurance, before that we would just refer them back to the provider to get PrEP, but now we actually start them and send them back to the provider to continue their PrEP. Holding an informational session with the providers to explain the goals of the grant project, and to improve the number of patients that are screened for HIV risk. And these were my deliverables. The first is an algorithm that we used, a tool that we used for assessing the risk of HIV. So those patients that were at nominal or very low risk, those with a moderate or moderately low risk, and those at increased risk of HIV, to separate those groups of people out so that those that weren't at high risk are screened, but not PrEP is not needed, so we don't need to do anything more. And then those that with low and moderate risk to be, if they want it, they can be given to them. But they're really the people that we're trying to assess are those people that are at increased risk for HIV and encourage them to take PrEP. And if not, document the reason why they don't want to take PrEP so that we can use that for future interventions to target more selectively those things that were issues for them. Then the table was developed to assist the providers in the intervals at which lab screenings are needed. With PrEP, we need to be looking at their kidney function regularly. For people that are over 50, it's every 6 months. For people under 50, it's once a year. Also looking at their lipid panel, their BMI, and then their STI screening. And this last deliverable is the changes that were made to the EHR, or electronic health record, that made it easier, more intuitive for the providers to document what they're doing when they their PrEP status. So just changing that one first box so that you can use more than one function on there, and not just limit it to one, and then moving up the whether or not patients were referred for PrEP services up to the top, and then documenting the education that they were given about PrEP and the reasons that they were declined, and adding in a little free text box so that we can say whatever their reason was that they had. So some of the contributions from the MPH program, from some of the coursework that was used, was the principles of biostatistics, the importance of data and assessing the clinical effectiveness, and in securing and keeping this grant funding that the project was based on, health PM 508, or health service delivery in the United States, knowing the different types of care funding and limitations of the funding, biologic basis of disease, the knowledge and contributing factors to illness and modes of prevention, and PM 547, public health policy and politics, how to approach policy changes and being aware of and preparing for adverse political climates. The overall experience was really good. As a provider, I found it really helpful to work with others and get a sense of the bigger picture of working toward decreasing the overall disease burden. And really, I really like the interprofessional collaboration. Most of the problems that were addressed were communication gaps between the epidemiologist and the providers, just not understanding, everybody working kind of towards the same goal, but with really different daily functions, and just being able to communicate and bring together these two different groups so that we as providers could understand the reasons for the data collection and what we needed to be doing in order to make that more effective. And then as a nurse practitioner, this practicum really has helped solidify my goal of wanting to create a dual NP-MPH degree. I believe that NPs are particularly suited to providing care for patients in public health, and a dual good degree would really enhance the leadership opportunities for NPs in public health. And these are my references. Thank you very much.